Hello, MedTech Insight enthusiasts. This is Dr. Jennifer Joe with my co-host, the fabulous Dr. Ami Bhatt. Ami's coming in live from Mass General Hospital, and I'm coming in live from my living room. When Dr. Bhatt isn't hosting the show, she's running the Massachusetts General Hospital telecardiology program, seeing congenital heart disease patients and teaching at the Harvard Medical School. When I'm not hosting the show, I see patients in the emergency room, urgent care, and hospitalist setting. We both support and consult traditional med tech and digital health startups. We both believe healthcare can be better, both for the clinician and for the patient. You can find us giving local, national, and international talks, and soon you'll see, I know I talk about this every time, Ami, our first ever Springer textbook on digital health.
September is our date. Yes, we got a date. It's September. It has an ISBN number already and can be looked up online. So we're almost there.
And purchase through Springer or Amazon? We don't know yet.
Purchase probably through Springer and Amazon, but we'll have more information hopefully at the next show or two.
MedTech Insights is a live, weekly interactive talk show led by me and Ami, where we interview two guest leaders in digital health every Tuesday at 12 noon Eastern Time. I know that some people have been asking how to be a leader. Please reach out to Jackie. How do you pronounce her last name, Ami?
Pagliaro.
Yes. And she will help schedule you. We are live. That means you can watch us on Facebook page, my and Ami's personal Facebook page, Vanguard.Health YouTube page, my personal LinkedIn page. And when you write comments in any of these places, meaning when you're on Facebook, LinkedIn, YouTube, and watching, and you want to say, hi, my name is, I'm watching from here. We love that. So please write that in and we'll feature it on the show. Also, you can ask questions to our lovely guest through your comments, and we'd love to have that and feature it on the show. All shows are recorded and available after the fact on our website, Vanguard.Health/MedTech Insights. Be sure to keep up with us by joining our mailing list and following us on social media. Over to you, Ami.
Fantastic. Hi, everybody. Hope everyone's having a good week. It's almost the middle of the summer already. I don't know where time goes. So today is an exciting day for us. We have really two pioneers in the field in thinking about digital health, thinking about just changing the way we provide healthcare, really going to the patient and saying, what are the things that are hard for our industry that really could be so much easier? And so we're excited to have them on. Before we start, just a quick reminder that both of our guests, as well as Dr. Joe and I, are all representing our own opinions and not those of the companies for whom we work or affiliate. With that in mind, today we have Brian Wang and Stephen Wunker. And so we'll start with Brian today. Brian is the Chief Scientific Officer and co-founder of Diag-Nose Medical, a medical device diagnostic startup that creates innovative point-of-care solutions to diagnose various types of rhinitis, including bacterial sinusitis, allergic, and non-allergic rhinitis, trying to figure out what's happening when you have those symptoms, whether or not you really need antibiotics, and solve that, time-old question of what should we do about this now. So point of care with Brian Wang. One very important thing, this is the first time, I think, Dr. Joe, this is the first time that we have a guest who is coming on their birthday. So let us bring on the birthday doctor, Dr. Brian Wang.
Oh, wow.
Hi, everyone.
Welcome to Brian. You turned 35.
Yeah, 21. That's right. All over again.
30-something.
30-something. There you go. Happy birthday, and thank you for spending this day with us. So, Brian, for those of you who don't know you as well as Jen and I do, will you give them a little bit of a backstory as to kind of who you are, your clinical course, but more importantly, how does somebody, as many of our audience members are clinicians, either who are entrepreneurs or looking to be an entrepreneur, how did you decide to do this? How did you end up getting into this? How does one have an idea and then actually make it happen?
So my interest in kind of innovation started, I would say, about 2 years ago. And so it was kind of serendipitous. I'd done some consulting for a medical device in the ENT space. So I'm a practicing otolaryngologist here in Houston, Texas. And I'd done some consulting for med device, and I really enjoyed my interactions with kind of industry contacts, but never had any kind of formal training or, education in that process. So about almost 2 years ago, exactly, a colleague of mine whom I met through kind of the Speakers Bureau circuit, he came and spoke to my former group, and he and I hit it off. And he said to me, hey, there's this course at Stanford. Stanford Biodesign is having this course for ENT innovation. And he said, you should come with me. And I was like, oh, that sounds pretty cool. It sounds interesting. And so we both enrolled, and we were paired up with a third ENT surgeon, Josie Hsu, who is from Toronto. And our fourth member, who is now our CEO, is a bioengineer from Australia. And so Eldon, Josie, David, and I were in the same group. And we were charged with creating a project that we would take from idea to implementation during this 4-day course at Stanford. It was probably the most intense course I've ever taken. We had classes from 8 to 5. We met after class, between classes, and basically had to present our idea in its fullest form as possible at the end of the course in front of a panel of judges who would then judge us against 3 other teams. And so from that, we actually won the team competition, and then got a lot of encouragement from mentors and advisors to pursue this afterwards. And that kind of was the seed, the seed that we kept watering, kept talking about, kept cultivating. And now it's, we are an early stage startup in past year two now. We've gone through our initial fundraising stage with friends and family. And now we're on the brink of a clinical trial, clinical study to kind of validate some of our ideas.
Fantastic. So exciting to be able to be in clinical medicine and then say, hey, look, there is more that I can do. So Jen, if I'm not mistaken, this is the second person who's come out of Stanford Biodesign on our show. We had somebody several weeks ago that did as well. We've also had those who've come out of some of the Texas design programs down in Miami as well. And then we have the Harvard Health Tech Fellows who are going to come join us in the fall from the incubator there. So for those people who are looking and interested, listen to what Dr. Wang is saying. It's a great opportunity to kickstart that interest. So Brian, I think you have a slide maybe that Jennifer can share. Will you tell us a little bit about Diag-Nose and what made you guys think about this topic and then how it works?
Oh, sure will. Yeah. So, at the beginning of the biodesign process, we're given kind of a whiteboard of sorts. And part of that process is just, thinking about anything. We actually were presented with several questions, and we chose kind of the sinusitis kind of category to kind of tackle. And then once you kind of choose your basic area, then you kind of just whiteboard things. You throw up ideas of, all right, what are the challenges? What are the issues with sinusitis? Okay, and so we then focused in on bacterial resistance, given the overprescription of antibiotics worldwide. And so with such an impactful problem, we said, well, how do we do this in a way that is cost effective, it's convenient, and improves kind of what our standard of care is? And so we wanted to create a non-invasive solution to that problem. No one likes getting their fingers stuck. No one likes getting things shoved up their nose, which is even more highlighted by the COVID pandemic. And so we said, why not just blowing your nose? It's something that's simple, that's familiar with children all the way up to older folks. And so our solution is kind of based upon this notion that you can blow your nose, and then within that sample, be able to diagnose kind of the source of the inflammation that's causing the nasal secretions. And so we wanted to have kind of that point of care solution that was simple, that was convenient. And currently our current assay idea is with lateral flow. And so lateral flow is very similar to what you would use in a urine pregnancy test. But then kind of bringing it to the kind of modern stage, we wanted a kind of a digital health component. And so a digital reader that would look at the readout of that lateral flow assay, and then be able to upload that in a kind of a telemedicine portal so that a telemedicine provider could see that result and then verify it, and then be able to diagnose and treat appropriately.
That's fantastic. So, being a telemedicine doc for many years myself, this is one of those things, right, where if I could only get my hands on the patient for certain things, and this is one where you look at them, you listen to the story, and it's really helpful to have that additional information. It's also, despite how used to sticking things up our noses we've all gotten during COVID. And the idea of not having to do that to get you a sample, right? And to be able to blow our nose and give you something. I think it's funny, but it's also serious. You cannot overstate the importance of making something that is going to lead to patient adoption.
For nose, I feel like we should have all just gotten, okay, I'm an ER doctor. We should have all just, and I do the swabs. I've been doing these type of swabs for a long time in the ER, and I think we should have just gotten used to the swabbing. Now, it's just your nose, that's fine. But I am going to underscore the clinical need that Brian has picked out and the ability for clinicians who are in it to really find unmet needs. So Brian, I worked for a second opinion company. We have a lot of those here in Boston, and a couple of them were acquired by Teladoc, and I used to work for them. And 10 to 30% of what I saw was sinusitis, because it's such, and especially sinusitis in Texas. It's a special, okay, in New England, you don't even understand what it's like to have sinusitis in Texas. It's like a profound other experience, and there's just no great way to figure out what's going on. And it's these things that go on for like 3 weeks, 6 weeks, and then sometimes months. But I love the fact that, Brian, that you from the Insider was like, this is a huge unmet need. There's got to be a fairly, there's got to be, with all the technology, ways to get to it and figure out what's going on.
Exactly. Yeah. So, Dr. Joe, you could speak to this as well. As what we see often is that a patient comes in with several days of congestion, runny nose, facial pain, pressure, postnasal drip, cough, sore throat. The diagnostic entities of bacterial sinusitis, viral rhinitis, viral rhinosinusitis, and allergic rhinitis all converge with those type of symptoms. So it's really hard for a provider to tell.
It's crazy hard. It's really hard.
Based on physical exam, is there a bacterial infection or not that requires antibiotics? And so, the classic story is patient comes in 5 days, and then they say, well, I got a Z-Pak, and 5 days later, I was so much better. So that's at day 10. If you look at most viral rhinosinusitis episodes, that's kind of when they start tapering down. So was it time? Was it the actual Z-Pak? So it's very unclear to the majority of providers, kind of in that just using time and physical examination. So we wanted to provide a layer of more accuracy, more diagnostic, objective data, so the provider could make a better decision when it comes to prescribing antibiotics or not.
Oh yeah, it's going to be huge. I mean, like in the urgent care. So outside of like the fact that it was 10 to 30% of like second opinion type scenarios where like someone's paying for a second opinion, it's probably like, depending on the season, 10 to 40% of what I see in the urgent care. And you're kind of looking for someone like more like Dr. Wang than me.
That's right.
By the second visit you are. The first
no, but somebody to solve this problem and to do it in a point of care manner, right? That's the other thing, is to really be able to do it without having to go through the entire medical health system for an answer that can actually be relatively straightforward and provided to you in the comfort of your own home. And I think
that's one of our ideas, is actually that not only could this be used in a primary care setting, but you could go to CVS, Walgreens, have it shipped to your home. You do the testing on site, maybe you go into their little minute clinic in the pharmacy. The provider there can see your objective result, or maybe you're sitting in the car outside the parking lot and you upload your result to the telehealth provider, and then they can do a visit with you on the spot. And so these are all kind of the iterations that we're thinking about. And I think all of them are impactful and helpful in their own way. So.
That's fantastic. So maybe, is this a good time? Jen, do we have comments, or can I bring on Steve right now?
We do have Dr. Chaudhary. So we do. Thank you. We love our audience members who watch, and we love to hear from you. We love to know what you're working on. We do have Dr. Shahab Chaudhary, Chief Medical Officer at ASSC, watching from New Jersey. He's in healthcare technology. Thank you for watching.
Fantastic. All right. So, speaking of point of care technology and thinking about innovation, Steve Wunker is Managing Director of New Market Advisors. It's a global firm focused particularly on disruptive innovation in healthcare. He's also the author of several award-winning business books and led Creighton Christensen's healthcare practice on disruptive innovation prior to starting New Market Advisors himself 12 years ago. So why don't we bring on Steve to join us as well?
Welcome, Steve.
Applause from two sources.
That's right. So glad to have you with us. So, Steve, we were starting to, bounce into point of care testing and thinking about its benefits. But before we go there, because I know that's an area that you have a lot of interest in, will you just tell our audience a little bit about, how you got to where you are, New Markets Advisors, and tell us a little bit about kind of your innovation take on how you look at companies?
You bet. So, look, I come at this from a pretty different perspective. I was a classic management consultant at Bain & Company many, many years ago. And then I was a tech and telecom entrepreneur, not focused on innovation. I was responsible for one of the first smartphones back in 1999. Wasn't a terribly good smartphone by today's standards, but it was one of the first. And built and sold a couple of companies around mobile technologies. And I linked up with Clayton Christensen, who is a professor at Harvard Business School, who was really focused on innovation and had written several best-selling books about innovation, like The Innovator's Dilemma, and coined the term disruptive innovation. And initially, the idea was to create a technology practice that I would be very involved in starting up and leading. It turned out that we had a lot of interest at the time. This is back in the mid 2000s in healthcare, and so we pivoted the focus of the company, and healthcare became a lot of what we did. So he put together a book called The Innovator's Prescription, which was published in 2010. And I was very involved in doing that, really looking at what are the disruptive trends in healthcare. It's been interesting to see how that played out over the next dozen years, pretty much. We started New Markets Advisors at about that time. So we're based in Boston, 20 people, also offices in Paris and in San Juan, Puerto Rico. And we focus on disruptive innovation largely in healthcare, as you said. So that's been the journey.
And so, I'm gonna ask you a couple questions that people, may or may not know, but there are some there's some terms that you have coined over time. There's some different ways that you've looked at innovation. And so I know we have a lot of young entrepreneurs out there who watch our show every week and are really excited to see what people like Dr. Wang are doing, but also equally interested in seeing what do people like you, Steve, look for? And so this is one question that comes up often from our audience when we have guests like you, which is, are there particular things that you say this is either the stage at which my company is interested and at which we like to invest? These are trends that we think are up and coming and interested in, and are there key things that people should, do to put their best foot forward? So let's start maybe with stages that you specifically invest in and trends that you see coming that you say, I'm interested in this.
Sure. Well, look, to be clear, we are advising large companies typically, often in life sciences, but we work with payers, we work with HIT providers, a range of firms. So we're advising them, and that means that we have their lens on. And really I would say there are two forms of firms that are most interesting to strategic investors or acquirers like them. So, look, you're in telecardiology, so you'll know that there are companies that are making pacemakers and ICDs that are very interested in what's next. So, for instance, Boston Scientific in the last quarter purchased Preventice for close to $1 billion. And that was a great example of finding an alternative to a Holter, something that might be more appropriate for heart failure patients, for instance, that is more accurate than weighing a patient every day, and combined with some algorithms that they have around HeartLogic and some of their implantable devices. Can really lead to prediction of decompensation and some pretty serious events. Right, so that bolsters the core business while adding in a little bit of extra revenue. And then there are other things like what Brian's been working on, which is it's a disruption. It creates a new category of consumption, fairly promising if you can get, obviously prove it out and then get the clinical adoption. And there are some firms that are more in that growth orientation, looking for new categories of revenue that are keenly interested in adding on things like that as a new line of business.
It's such a true statement. So I learned yesterday, Jen, I don't know if I told you this one. So yesterday I just learned that the Apple Watch 7, and maybe everybody else knows this already, is going to have infrared technology that does continuous glucose monitoring. So there was a company, and I don't remember their name right now, that was actually bought out by them, I think right around when they were doing kind of Apple Watch 5 or so. And so now the 7 has incorporated that. And so there's going to be point of care glucose monitoring. I don't know if you remember on the show, I was wearing one of the continuous glucose monitors. I need to see what happened when I was eating bagels in the morning. I just needed to establish that to make myself stop. But now we're
it was a sub-Q continuous glucose monitor that you popped on your...
It poked right in, and it was right there. Yeah, and every time you move your shoulder against the chair by mistake, it hurt a little bit. But
and you're afraid of doing swabs in your nose.
Oh.
just out of curiosity.
I love that. No judgment here on this show. No judgment on the show. But I think this is moving fast. Point of care and the idea of people having control over their own numbers. People having the ability to get an answer to their own question and do it in a way that doesn't involve the various levels that you have to go through to get to Dr. Wang, for example, right? They would have to go through you, Jennifer, maybe in an ER or through an urgent care. There would be a history that we know is not going to give an answer most likely, right? And then there'd be a physical exam where just everything's going to hurt when you push. And at the end of the day, you end up, getting some sort of an assessment. And so I think our system, our healthcare system, really doesn't allow for the ease of care for relatively simple questions and answers, right? So I think that's really important. So maybe Steve and then Brian, thinking a little bit about point of care. Steve, I think there's a couple companies that you are working with that are thinking about that. There are a lot of obvious benefits to it. Are there things that we're not thinking about that make it more promising in terms of how we're going to change the delivery of healthcare or the disruption of healthcare?
So a couple things. I think from a reimbursement standpoint, look, a lot is being done at point of care, and then it's being done again in a core lab. And that's very time inefficient. It's worse from a patient care perspective, and it's also expensive for the provider. And ultimately for the payer as well. So doing it once, doing it right at point of care has a lot of benefits. But look, the other thing to really note about how you make this work at the coalface, whether it's a PCP or a specialist who's just seeing a high volume of patients, is that you can't overload the doc with data. And I think a lot of, particularly in the digital field, a lot of firms have been doing that, right? So CGM is overwhelming in the data that it provides. An ICD is going to give you an overwhelming amount of data and sometimes an overwhelming number of alerts. And you can't respond to 20 alerts a week. So determining what is really the most important and actionable data, and then simplifying that both for patient self-management as well as for either a physician or the care team around the physician is one of those critical next steps. And you mentioned, what's the Apple Watch going to do? Hopefully, it's not just going to take better readings via infrared, because I doubt that's the case. It's not going to be a better CGM than Dexcom, but maybe it makes that data much more intuitive and actionable. That would be a real advancement.
So maybe thinking about that, Brian, as we're looking at what do clinical trials in this arena look like, how much proof do we need for people to trust point of care to the point where they're not going to repeat it? Just your thoughts on moving forward with that.
Oh, that's an excellent question, right? How much data do we need to kind of to validate the technology? I think that's something that will evolve and kind of shape over time. We all want, kind of that level 1 evidence for anything, right? But I think the reality of it is that so often you have to do, and this is especially in the ENT literature, you have to go with what's most available and kind of widespread. If that's level 2 evidence, then so be it, because our standards of care are often not necessarily evidence-based, but we're trying to move that direction. I think what we're just trying to do is move the needle so that there's just again a layer of objectivity by which we're assessing patients, and ultimately our device, if it kind of gives you some objectivity by which you can then make decisions about whether or not this patient needs a specialist to kind of intervene and assess the patient, that's already kind of maybe saving that patient, trips to the PCP, going and getting cold medicine. So there's just so many kind of ways in which, even if you should move the needle a little bit closer, in terms of accuracy to what's truly going on, you can have impact that's that's kind of multiple, and twofold, threefold. So I think that's what we're trying to do. We're not trying to go for the highest sensitivity, highest specificity of any test, but we're just trying to do better than what's done before. And again, with time, our first iteration will be different, I'm sure, from the second one. And if we can improve on those and do better than the device or assay before, then we're making progress. And again, moving the needle slightly towards more conscientious patient care.
I love that phrase, Brian, conscientious patient care. There is such a burden. I mean, we talk about the kind of burden that physicians and nurses face right now, right, in terms of administrative burden, but also in terms of volume, right? The volume of work that they're doing and what is burning them out.
Right.
And it's interesting because nobody means to not be conscientious, but at the end of the day, sometimes it is faster to not argue with a patient who's feeling unwell for 5 days and
Absolutely.
last time felt better with a Z-Pak.
Yes.
Now, there's an entire industry of people who believe in the gut biome so strongly
Oh,
that
yes.
it is not just antibiotic resistance, but like, gosh, what else are we changing that we don't know about yet? Where we'll look back in 20 years.
That's absolutely true. I mean, the antibiotics, everyone knows kind of, well, it just made my stomach upset. The ramifications of kind of antibiotic resistance, multiple antibiotics, look at children. There are now studies showing that children who get antibiotics early in life multiple times with some regular frequency end up being more atopic, right? And so there's a lot of interest now looking at restricting the use of antibiotics, being appropriate with antibiotics. And obviously the bigger thing that we're aware of now is the emerging antimicrobial resistance, which WHO has listed as one of their top priorities. This is pre-COVID, and so really it's so impactful. And again, if we can just move the needle a little bit, I think we can make a difference.
Brian, do you see a role for this in kind of developing countries as well? And if so, what does that role look like?
Absolutely. And I think we're very conscientious of cost. And that was one of our main goals in developing our device and assays, that we wanted something low cost, that was easy to produce, that was low cost to provider or kind of a health system that could be distributed on multiple levels, whether again it's to primary care providers, to public health clinics. So yes, I think it can be impactful because antibiotics are cheap. If you look at the average generic antibiotic script, it's probably a few dollars, and so it's become it is a marvel of the modern world. But again, there's downsides to those marvels and those type of interventions. So judicious use of these antibiotics, even in the developing world, is as important as that in the modernized world. So
that's great. Oh, we have a lot of people watching today. Sonia, great to see you. Sonia Tita Pupolo. Actually, she herself, she says, feeling grateful and loving your show. But Sonia has a beautiful show herself, actually. She had some great podcasts. And so for anybody who hasn't actually met her yet, worth looking into her. Really just innovative thoughts and makes you look at the world a different way. And I saw Denise Silber earlier had added commentary, watching from Paris, France. Denise, great to see you. Bastille Day tomorrow. I had made a reservation at Laval for tomorrow, but now I have some extra urgent patients that need to come in. So Laval, he'll have to wait for a non-Bastille Day, but happy Bastille Day to those who are watching from France and other places. Excited for you. And of course, New Jersey. God bless. Go New Jersey. That's great. Wonderful. Jennifer, questions that you might have for these two?
I want to dig into what Steve was saying a little bit more, just because I do think point of care testing has changed dramatically. Like, I think the technology has changed. I think we've had a lot of investments, but also I think the willingness for clinicians and also the greater American public to embrace point of care testing and technology and to see the benefit. Brian was saying was clinicians struggle with this all the time. And sometimes we want, or we desire closer. Nothing in medicine is an absolute yes or no. There's lots of factors that play into it. And then it's understanding the body of evidence, the testing you're utilizing, and what's in front of you. With that said, there was COVID, I think, has rapidly allowed us to say, look, we need to innovate more rapidly. We need to be more accepting of new technology that's coming out. And we need to also be more accepting of different distribution channels for that point of care testing. So I think it's actually very different now. So I'd love to hear what Steve thinks. And then, I think that feeds into Brian, which you're building, which is allowing you, maybe it's never going to get us 100%. It's never going to get us to 90% bacterial versus viral. And also, I think it changes a lot. I say this from someone who's struggled from a lot of sinusitis, and I've done everything. I've done the nose strips. I've done the shooting water up my nose. I did the shooting water up my nose. Beware, you need to boil it ahead of time because there's some amoeba that lives in a deep lake or something that could then infiltrate my brain. It's crazy to manage. But if we could allow more technologies to come out, but also be distributed, meaning like the CVSs of the world, the Minute Clinics of the world, or even like the CIC Healths of the world, so that there's just more access, I think that's really interesting. Sorry, Steve, I wanted to hear your thoughts on this.
No worries. So, Jen, I shared a graphic from a recent working paper that you might want to bring up because I think it's relevant here. And folks, we've got a lot of working papers on the website, newmarketsadvisors.com, advisors and markets with an S. So feel free to download these. But this was from a paper titled "What Behavior Changes Will Stick After the Coronavirus?" Yeah, it's a question a lot of people have. And so there's a model here that actually draws from my first book, Capturing New Markets, where this is explored in detail, but this is sort of the cliff notes to that, or a part of that. So
doctors like cliff notes.
The yellow and black cover was not allowed, so anyway, I went with this. But in any sort of market, when you look at what's really going to last as behavior change, you need to look at a few factors that should combine and strengthen each other. And that's why it's sort of these interlocking circles. So you need to have some core motivation shifting. So let's use the example of point of care diagnostics, right? So in this case, patients are more expectant that they will get a read right there at the point of care. And they are more accepting also of going to alternative sites of care, like a Minute Clinic, to get that if the physician won't do it right there and then in a time frame that's convenient for them, and that allows them to take action that might actually affect the course of a disease. Of course, there has to be an appeal of new approaches. That's sort of intuitive. What's remarkable, though, is how many entrepreneurs just focus on that and they ignore all the other stuff that has to go around it. And there's a lot of great ideas that don't get traction because they don't, look at these other factors. And then you need something to break inertia. There's so much inertia in healthcare. COVID has done that. And then things will resume and attain their inertia, right? So like with telemedicine, right? It has done that in a very significant way. And then people will get used to certain patterns of workflows and ways that they see their provider. So it will recongeal. This has been a great opportunity for it. There's critical mass. And so there's widespread enough knowledge about how to adopt these new mechanisms. Workflows have changed. The other clinicians in a practice have gotten used to these other ways of working. So that's been a great determinant of future success. And then finally, get the infrastructure. So we have large providers who have put in their systems to accommodate this more, whether it's the distribution of even of like point of care PCR tests, not just antigen tests, that are distributed now throughout their networks, or the telemedicine features that are now embedded in their EMRs. So the infrastructure is locked in that change. So this, certainly there are many changes in COVID that aren't going to stick. We're not still hoarding toilet paper, I hope, right? But we are going to be doing things like getting more diagnoses at the point of care and doing more telemedicine consults.
So I have to say, so the four of us, Jen, will you put that back up?
Oh, okay.
The four of us here, right, are early adopters or visionaries, whatever you want to call ourselves on a given day. 1, 2, and 3 are so exciting. You see 1, 2, and 3, and you say, yes, core motivation shifted, new approaches, people are all coming around, inertia's ending. And then you get to only for inertia to resume in this new way. And then you get to critical mass is achieved. And so I guess I have a question for both of you, which is, critical mass is achieved. Do we really nowadays need critical mass to accept all of the new technologies, all of the disruption that we're bringing forward? Or can we say this disruption is an option in a toolbox for you to use? And there are several other disruptions. And I feel like there is room, both in terms of investment and in terms of scientific progress, to have multiple things. The question then becomes, how do you get to number 6? How do you take multiple things and put them in an infrastructure? I work in many very large organizations, and we're all working hard to say, infrastructure, how do you not lock in change, but accept change and then iterate on change and then be agile with the next change? And so I still think we have a lot of room to do on 4, 5, and 6. And I would just love to hear your experiences, Brian and Steve, and how do you iterate? How are you getting people to accept the idea that this may be one of many? And then how will we get them to do this again? Neither one of you is done with what you're doing right now. You will do more. We will bring you back to hear about the next great thing. Maybe Brian, you first.
I'm going to test my nose for bacterial versus viral sinusitis.
Yeah.
I'm going to blow. No, I'm okay with swab if you have a swab. I'll swab myself. Go ahead, sorry.
We're happy to send you a working prototype when that's ready. So that's a great question. I mean, I think, how do you incorporate change, especially in these large, multi-level, multi-layer systems that we work in. I work for a large healthcare system, and we talked about this. We talk about this in how do we get adoption? How do we get adoption and implementation and buy-in from providers? And I think really what you have to do is figure out who are the influencers. Mm-hmm. Who are the influencers that said, hey, we're going to start having this diagnostic test in our clinics. And I think we looked at how you have to look at how healthcare is delivered where you are. You have to look at how things are structured, and then figure out who the influences are. And so if it's a private group, we thought, okay, well, what if we approach private practice individuals who have, let's say, a primary care group? Is it the administrator that we talk to? Is the chief medical officer of that group? And then we pitch them on all these things, all these points that we talked about. And there were this cost, efficiency, workflow, reimbursement on there, for using the test. And then what's the resulting effect of that? So those are kind of my preliminary ideas of kind of how we would approach this. The larger scale entities are going to be probably more challenging. But if they can see a track record, you can then, start small and see that, wow, this has really made a difference in outcomes with patients. I think that's when you can start getting a little bit of interest and buy-in from these larger entities. I think the biggest, and this is what I've heard from advisors and mentors, is that one of the biggest challenges to get insurers to cover. Insurers typically are the last to come on board with any type of innovation, and I could be wrong, but this is kind of the feedback that we got. Insurers really want to see a lot of data, a lot of objectivity, and true validation of whatever intervention that is before they start putting their resources behind it and covering it. So again, that kind of helped us frame what we're doing in terms of cost and convenience.
That's right. It makes you wonder whether the Kaisers or Geisingers or even the crossover health, right? The people who are taking responsibility and really are moving the needle a little bit towards value, because they're not just the insurers. They're the insurers and they're the providers.
Correct.
And maybe that's a place to start. Steve, your thoughts?
So I was going to say something along those lines, Ami, that you need to have a view about who is the foothold market, which is different from who's the ultimate market, right? What is the profile of the early adopter? Hmm. And, I see a lot of firms, particularly, large firms, but also particularly smaller medtech firms, are going out there and they're pitching Mass General Brigham and Kaiser and Ascension, and they're all appealing because they're large health systems, but they are completely different. And a lot of payers are completely different too. And so you really have to have a very segmented view about who is your target early adopter, and hone that proposition for them, hone the influencers you're leveraging for them, and then that's how you build critical mass. That's how it should work typically in healthcare. I think COVID has really shaken things up and allowed people to skip stages a little bit. That's ending. And so going forward, you need to really know what is the proposition for whom. It's not everything you're excited by, but it's a super compelling for that narrow audience.
That's fantastic. I see we're coming up on time. I know we say we're a half-hour show. I think somehow we've all assumed, audience and members alike, that we're about a 45-minute show. But this has been wonderful. Thank you both for spending kind of the time with us. Oh, Matthew comes to us, watching from Boston, patent attorney, focusing on medical device technologies. Thanks for the program today. Matthew, thank you for being with us and taking the time over your lunch break. So, I think maybe if we could just end with, each of your closing thoughts. Our audience has entrepreneurs, we have investors, we have advisors, we have students, and we have practicing clinicians. If you had to pick one or two things that you want, people to know moving forward about how they can be involved in disrupting healthcare for the benefit of our patients, maybe Brian and then Steve would love to hear your closing thoughts.
Yeah, so I would really kind of seek out resources amongst your colleagues, but people that you recognize, you respect. We all go to conferences, COVID aside, we attend conferences with influencers in our fields and to really pick brains. And I think most people are open to that. So really just kind of pick the brains of people that you respect, recognize. You see their papers, you see their talks, and really try to see in which ways. A lot of them are advisors and consultants, and some of them have started their own startups. And so I think that's helpful. And that's how I got into it, is really just through colleagues and finding resources like Stanford Biodesign. Their full fellowship, it would be amazing to do. And a lot of physicians, a lot of those fellows are physicians who then go on to, MedTech and innovation afterwards. I think kind of one just general piece of advice is that, failure is part of it. And I think we as physicians are very driven people and are very afraid of failure, but I think you have to embrace it. You have to embrace that failure is part of what we do, and especially in innovation. And you have to kind of just say, look, okay, failure is possible, and we're all worried about risk, but without risk, there is no reward. And you do things to mitigate your risks and risk of failure, but just know that, it's okay. And from that failure, and I'm talking about this a lot because I'm reading a book about this that a friend of mine wrote about failure, is that from those failures come amazing things. And there's so many cases of that, whether it's Steve Jobs, Coach K, those are people in this book. And it's really not being afraid to fail, because from those things, from those failures and experiences, often the best ideas come forth. So
that is
failure.
fantastic.
Yeah.
Fantastic advice. Fantastic.
My tennis coach used to tell me that I had to be losing 50% of the time and winning 50% of the time. If I wasn't losing 50% of the time, at least not in competition. She'd prefer for me to lose, like not in an active. But no, I think it's key. It's if you're not losing a fair amount of the time, you're not pushing yourself hard enough to grow.
That's correct.
That's what she used to say.
Yeah, and in the innovation space, that's really true. We have an amazing CEO. He's this whiz kid. I call him a whiz kid out of Australia. And he drives the ship. And, we always talk about risk. And we're always de-risking, right? It's all about, all right, what are we doing wrong? We have advisors and experts and people like Steve who poke holes. What we learned about is, all right, have someone come and poke holes and see when the water comes out, what do you have left, right? So we're always poking holes, and you have to have people that are willing to poke holes, and you have to be willing to poke holes in yourself to see where your weaknesses are. Because if you know where your weaknesses are, then you know where you have to work harder on, and where you have to grow. And so,
it's very not Asian of you.
Dr. Joe, only you can say that right now.
That's right. Well, only you can say it a little bit. It's okay.
So I will say I pulled up my phone. I'm sorry, I don't usually do this during a show, but it just made me think of something. Brian and I know each other. We were both at Yale at the same time. And tonight, actually, the Yale alumni is hosting an event, and it is called, or tomorrow night, I'm sorry, and it's called Failing Up as an Entrepreneur. And it's a fireside chat with Jane Park, who's the CEO of Tokki, T-O-K-K-I. But I love that, failing up as an entrepreneur. And that's echoing exactly what Dr. Wang is saying, right? That's how we get places. So I love the thought. Steve, final word for you.
Know your target use case. There are so many things that entrepreneurs want to do. If you want one example, look at what Intuitive did with Da Vinci. They could have done so much around robotic surgery, right? And now today they're getting there, but they focused on radical prostatectomy as a low risk enough procedure that if things went wrong, you wouldn't kill the patient. But where there is one critical advantage of robotics and nerve sparing, and where the visualization benefits could also be notable. So it wasn't just the degrees of freedom, but there were other aspects of the platform that they could really bring out and market to. And then they looked both narrowly, but they also thought broadly that, hey, we're selling a marketing tool for hospitals. We're not just selling a tool to surgeons. And they push the heck out of that to really succeed. So it's focus, and then within your focus, think broadly about all the degrees of freedom that you have, and what really makes your solution compelling, not just to your target buyer, but to the suite of influencers around them that have to buy in for change to occur.
Fantastic, fantastic. Well, Brian and Steve, thank you both so much for being with us. We really appreciate it. I think this has been it's been a show where there's been so much good advice that everyone can actually take home and use, and I love that for our audience. Dr. Joe, I will give you the last word.
Really appreciate having Steve and Brian on the show. Really love what you're doing. Looking forward to your successes. Thank you to our audience members for watching every Tuesday at 12 noon, and we will see you next week. See you later, everybody.
Bye-bye.
Take care.